So for those of you who just joined us, I would like to welcome you. This is the second part of our program for the Health Systems event. And we have a fantastic panel of speakers with us this afternoon. I'm going to introduce our moderator, Dr. Tabia Akintobi. She's joining us from Morehouse School of Medicine. And she's wearing a variety of hats there, which I'm not going to go in detail one by one because we'll be here for a long time to list all of the wonderful things that she's doing there. But some of her focus there is on prevention. You may remember we talked about moving from sick care to health care. How can we do better on that end so we don't have to spend a lot of time on the treatment. So some of her focus is on that area, which aligns perfectly with this panel and the overall program. So I'm going to hand it over to her, and she's going to introduce our speakers. Thank you very much again for joining us.
Thank you so much, Pinar, and this is just such a wonderful opportunity to hear from panelists who will help us to think about connecting the dots. So through this afternoon, of course, you've heard from researchers who have talked about the work that they're doing, of course, in the engineering, biomedical spaces, et cetera. And I suspect that part of the reason why I was asked to moderate this panel is because my space is in the area of research translation, right? So when we think about the proverbial moving of the needle, right? So advancing the health of communities and populations, there are three buckets of leadership that are critical. Certainly there's the research bucket, so that evidence-based approaches that shape the way that we do practice, whether it's clinical practice, biomedical engineering, among many other spaces. And then there are those of us who are in the practice spaces, which are really central. And then the third leg of that stool is policy systems and environmental change agents. So we need high touch with communities, we need research rigor, and we also need those outside of the academy who can take the research knowledge and say, so what? What does this mean in real world settings, right? So in my world, we call that implementation science, right? Looking at how research is translated. So I'm sure that our panelists will be speaking to these spaces as we think about connecting the dots. So the first speaker that we'll have come up, and I'll introduce them a bit and have them talk more about themselves as they come up, is Bridget Hurley. She is with Evidation Health, and she's the VP of Clinical and Regulatory issues within that organization. So Bridget is the VP of Clinical and Regulatory at Evidation Health, based in San Mateo, California. And Evidation is a new kind of health and measurement area that provides the technology and the guidance to understand how everyday behavior and health interact. So she has over 20 years of US and international experience, and as she tees up, she can join me up here. In medical device production, development, and clinical and regulatory affairs. In talking with her briefly, I know that she is also a Georgia Tech alum. So I kind of get the sense that students give back and come back, right? And so hopefully as she talks about her area, she will bring that expertise in our discussions about how we connect the dots. So Bridget, welcome, and we'll introduce our other panelists after you. There's your...
Okay, perfect. So thank you for having me here today. I'm going to tell you a little bit more about Evidation, but I enjoy being back on campus. I can say it's very, very different than when I was here a long time ago in grad school. There are a lot of new buildings, which is great. So today I'm going to talk a little bit about Evidation, and from the perspective of how Evidation is looking at driving healthcare changes, really by empowering the patient. So we're looking at how that patient is at the center of what we see of healthcare change. So I thought I'd start just first looking back, and I have a lot of background in both medical device product development as well as clinical trials. And really looking at what the gold standard is when we go to develop products and bring a product to market, it's getting that data that will support FDA approval and ultimately the treatment guidelines. So to develop those studies, it's the basis of that is really a randomized control trial. And when we look at those studies, they have very, very narrow inclusion criteria. It's looking at enrolling patients with very specific inclusion elements to meet that trial's needs. They're performed at very limited clinical sites across the US, typically large research centers, academic university hospitals. And they also follow those patients very thoroughly. So they're looking at that patient coming back into the clinic every 1 month, 3 months, et cetera, to gather that data that will support ultimately the results that hopefully show a very discrete difference between that arm that had the drug or the device versus the arm that did not. And that ultimately is used to support that approval process. But I think when you step back and look at those 20 or 30 clinical sites that were part of those trials early on, they draw from a very specific patient population. And then you have to question, how does that translate to the real world when it is ultimately released into the market? And the patient population is not just around those 20 university hospitals. It's very broadly based in the US. And I think if I take an example then, did I skip a slide? Yeah. So if I take an example of congestive heart failure, really that's looking at, there were 3 landmark trials. There are 5.7 million patients in the US with heart failure, and there were 3 trials that enrolled 20,000 patients, which sounds like a lot of patients, but when you look at those 3 trials and understand how those today represent the patients that are being treated, those set the standard for the drugs that are being used to treat heart failure patients. But the heart failure patients being treated today, only 1 in 5 would have been eligible for those trials. And actually only 1 in 8 women would have been eligible for those trials. But yet we use those drugs in all patients as if they are, those data represent the patients today. So I think that's a big part as we talk about digital health streams and how that will change our medical world going forward. So at Evidation, we really see patients like this. They're individuals out there in everyday life, and we're looking at all of the contextual data, all of the connected data that we're streaming all around us from our phones, from our watches, from our Fitbits. And we're looking at that to harness that data to understand what are the signals in that data that will help us understand and measure health outcomes. So if I take 2 of our recent studies, we run virtual clinical studies. So what does that mean? We essentially recruit online, participants consent online, and they do pretty much all of the activities from wherever they are, whenever they need to. And if looking at these 2 studies, one was in uncontrolled hypertension and one was in sleep apnea. In the sleep apnea study, we actually enrolled more than 1,000 patients in less than 24 hours. So that gives you the scale that you can do these clinical studies, which is very different than a traditional clinical study that can take months to years to enroll. If you look at the uncontrolled hypertension study, each one of those dots represents an enrollment of a patient across the US. So you can see it's a much more diverse map versus those 20 discrete clinical sites that you would see in a typical clinical study. The other part of looking at the digital data is that we're no longer limited to those 3 episodic events where the patient came back to the clinic, we took their vitals, maybe they did a treadmill test. We're now looking at all of the data that we're streaming, that continuous data of the patient, to understand much more about how that patient is either feeling, functioning, beyond just those 3 days that they went back to the clinic. And I think the important part about this is thinking, how it's really trying to understand now that patient as their own control. How far did they walk 2 weeks ago? How far did they walk yesterday? How far do they walk today? Versus how far did they walk on the treadmill when they came into the office 3 months ago? That may have been a good day for them, it may not have been a good day. And this gives you a much better picture of that patient in their everyday life. So as we look at these new data sources, what we look at differently is that we can now ask different questions and we can answer those questions differently with the data that we have. So now we can think about how can I quantify a level of pain in a chronic pain patient? How could I potentially use this data to measure the recovery post-surgery of a patient? How could I use this data potentially to understand if I can detect cognitive decline early on in an Alzheimer's patient differently than I could in a traditional medical sense? So at Evidation, we have more than 2 million patients and connected individuals in our patient population. All of these individuals essentially have permissioned their data to us, and that's data across all of their wearable data, but it also is traditional medical data. So we match that data with claims data, with EMR data. It can be at-home diagnostic tests, and then we also overlay that with contextual data. So it can be geolocation tracking. It could also be looking at pollen counts. If you think about an asthma group, it could be looking at weather patterns to just understand, did I not go running yesterday because it was raining outside, or did I not go running because I was sick yesterday? So if I link this back, all of this then translates to obviously more patients and more data. But I think the other important aspect is that it's a much broader population. It's a much more representative population that's much more diverse than we see in traditional clinical studies. So if I go back to that hypertension study that we ran, again, this was looking at hypertension. We had a blood pressure measurement tool that was Bluetooth connected to an app, so we were gathering a lot of data about these patients. But in that patient population that was completely recruited online, no person ever had to go to a clinical site, no person was seen in person. But in that data set, if you look at the demographics, we had 57% female, almost 30% African American or Hispanic, and almost 50% without a college degree. And those are actually fairly underrepresented populations in traditional clinical studies. So this is really some of the power that we see in doing clinical studies virtually. And definitely this is where Evidation sees the power of using this to change healthcare going forward. Thank you. I think time for one question, or we?
Yes,
yeah.
You are well within time.
All right.
It's refreshing. So we have a couple of questions, and we maybe because we've gained a bit of time, we can take two. All right, go ahead. Hopefully you can project.
Okay, so with the virtual trials, I assume people kind of fall out of the study over time. Is there a difference between the fallout rate in virtual trials versus the clinical site trials?
Yeah, no, that's a really good. It's a really good question. We actually have seen that, and of course we're monitoring the data remotely the entire time. We can reach out to participants if we see they're not performing certain tasks. We actually have found that if you look at our follow-through rates all the way to the end of studies, which some of our studies are a year plus, we have easily 80 to 90% completion rates within the groups, which is actually higher than what you can see in some traditional clinical studies. Part of that's because they don't have to go into a clinical office, right? They can do these surveys. They're just connecting an app. The data's just flowing to us. So we actually see, and we've done studies in older populations as well, and we haven't seen that there's differences. You might think, well, this is maybe only for the younger population, but we've done Medicare-based studies, the hypertension study, for example, and didn't see a difference.
So, this is fabulous. Can you talk just a little bit about the always-on data sources and how do you get it out to your population? How do you get the apps or the wearables out to these big populations? And then what have you done to compare these with gold standard type tests
Yep.
to gain some confidence in them?
Yeah, so I think from the perspective of data, we can essentially integrate with anything with an API. So we can, obviously Fitbit, we're probably one of the companies that has the most Fitbit data besides Fitbit. And essentially there's an API, when you go into our app, you connect in saying, yes, I allow my Fitbit data to come to Evidation. So you can do that with essentially all of your healthcare apps. It could be, we do that with anything from like a meditation app like Headspace to Fitbit. And all of that data flows in. It's on almost a real-time basis. And then the other side is that if you had your own app, obviously we work with various digital health companies that might be looking to collect specific data. It could be glucose data, it could be asthma data, that we integrate specifically so that we gather that data for that particular client. What was the second part of your question?
Is this, how do these app-based compare with other
with gold standards.
clinical trial.
Yeah, and I think this is part where we're trying to understand, those gold standards. If I take like the 6-minute walk test, which is used traditionally to sort of understand over time how a patient is maybe progressing in heart failure or in bronchitis, it's not necessarily really the 6-minute walk test. All they're looking for is how far do you walk in 6 minutes. Whereas we would look at it more from an activity-based measurement. So how far are they walking where you use me as my own control? How far did I walk? We look at everything from obviously activity, heart rate, sleep parameters, and it's understanding how all of that data changes longitudinally for that patient and within a patient population.
So we ask you to continue to jot your questions down. Let's give Bridget a hand. So we'll take time for a question or two after each speaker, but certainly if you have others, we're certainly saving time at the end for other kind of cross-cutting questions and some that I'll pose as well. So our next speaker is Jim McClelland, and he's with the state of Indiana and the Executive Director of Drug Prevention, Treatment, and Enforcement. So in January of 2017, Governor Eric Holcomb appointed Jim McClelland to the newly created position of Executive Director for Drug Prevention, Treatment, and Enforcement for the state of Indiana. He reports directly to the governor and also chairs the Indiana Commission to Combat Drug Abuse. So this sounds like policy, systems, and environment, right? So as Indiana's drug czar, Jim is charged with coordinating, aligning, and focusing the relevant work of a wide array of state agencies that affect substance abuse issues. In addition, he seeks to leverage the state's resources with those of entities in other sectors, business, higher education, healthcare, among many others. So connecting the dots across all of the players in advancing population-based health and hopefully decreasing the incidence and prevalence of substance abuse-related health issues. So I'm sure he'll say much more, but I'll ask him to come up now and tell us more about his work.
Okay, thank you, Tavia. And I'm not going to talk just about that, but really about an array of experiences that I've had over the last couple of decades where I've had the privilege of being involved in a couple of major problems in our society and trying to reduce them at least. Intergenerational poverty being the first, and then the last 2 years, the opioid crisis. So what I want to do is share with you some conclusions that I've drawn from all of that work and describe a path that I think, if replicated enough, would help us reduce a lot of social problems in our society and go a long way toward helping to build stronger, healthier communities for all. There's a lot of data showing how many of our society's social problems, poverty, low education levels, crime rates, births to young unwed mothers in low-income households, a host of health issues are frequently interrelated, and they reinforce and compound each other. But for a long time in our society, we've not tended to treat them as if they were related. We have a tendency to treat them in isolation, one from another. The public sector tends to do that through its silos, while the not-for-profit sector that I was part of for most of my adult life looks more like this. It's an incredibly fragmented sector, a lot of organizations doing a lot of really good things, but each one typically focused on a piece of a much larger, more complex set of issues. And we've not been very good at connecting the pieces or connecting the dots. And this is where we've got a lot of work to do. Siloed, of course, the healthcare system itself, let's just call it the healthcare sector in this country itself is incredibly fragmented, more often than not. Siloed and fragmented approaches to are seldom have lasting impact when they're trying to deal with complex social problems, and we've just got to find a better way to connect the pieces. So let's take a look at the opioid situation in particular. Drug overdoses, 2/3 of which are opioid related, are now the leading cause of death of Americans under age 50, and they are a major factor in a decline in the average lifespan of Americans for 2 consecutive years, and that is something that's not happening in any other developed country on the face of the earth. While all states are affected by the opioid crisis, the problem is more prevalent in some areas than others. There was a study that was done at Syracuse University, published earlier this year by the American Journal of Preventive Medicine, that analyzed over 500,000 drug-related deaths between 2006 and 2015, and they compared them county by county with various social and economic factors. I'm going to quote from a summary of those findings. Controlling for county demographic characteristics, average mortality rates were significantly higher in counties with greater economic and family distress. Now, another piece of this, there's strong comorbidity between mental illness and substance use disorders. 45% of people with a substance use disorder also have a mental disorder, yet only 51% receive treatment for either disorder, and only a very small minority receive treatment for both. Now, the implications of this are sobering. Purdue University just published a study last month that found that for every additional 1% of the population with a depression diagnosis, opioid-related deaths rose 26%. And when you consider that less than 1/4 of all persons diagnosed with an opioid use disorder are receiving any specialty treatment, and that the gold standard for such treatment is medication assisted, that is, medication combined with behavioral therapies and psychosocial supports, there's a strong case for integrating or at least co-locating primary care, mental health, and addiction treatment services. The Surgeon General's recently published report, Facing Addiction in America, states, integrating substance use disorder services as well as screening for early risk factors for substance use disorders into mainstream health care and ensuring that all Americans have access to those services has the power to substantially improve outcomes for individuals and reverse the opioid crisis. These actions may reduce overall health care costs for individuals and their families, reduce health disparities among high-risk groups, and reduce costs for healthcare systems and communities. Now, in addition, providing non-medical services in conjunction with primary care, in other words, wraparound services, can help improve patient outcomes and reduce overall healthcare spending. Eskenazi Health, which is a safety net provider in Indianapolis, introduced wraparound services at its federally qualified health centers. Behavioral health, social work, dietetics, patient navigation, and other wraparound services were co-located with primary care services, and in an 11-year panel of primary care patients, receipt of any wraparound service was associated with a reduction in hospitalizations and emergency department visits. The estimated savings from potentially avoided hospitalizations alone was $1.4 million a year. Now, let's look at risk factors for just a minute. Among the most significant risk factors for substance use disorder are adverse, by the way, I was a little late on that one. Among the most significant risk factors for substance use disorder are adverse childhood experiences, known as ACEs, ACE. Examples are physical, emotional, or sexual abuse, death of a parent, divorce, mental illness of a parent, substance abuse by a parent, incarceration of a parent. Over the last 20 years, we have learned a lot about the cumulative effects of ACEs. The more a child has, in other words, the higher the child's ACE score, the greater the risk of a number of negative social and economic outcomes, including lower graduation rates, adolescent pregnancies, sexual violence, poor work performance, and financial stress. High ACE scores are also associated with smoking, depression, a host of chronic diseases, including alcoholism and substance use disorders, and early death. One study by SAMHSA, which is the Substance Abuse and Mental Health Services Administration, found that every additional ACE increased the rate of prescription drug use by 62%, and the likelihood of early initiation of illicit drug use by 2 to 4 times. Now, I have to tell you, there is nothing about the opioid crisis that troubles me more than the impact on kids. Parental substance abuse is a factor in 2/3 of all child maltreatment cases, and in over half of the cases where children are being removed from their homes by Child Protective Services. And then, of course, there are the kids who are losing parents because the parents are overdosing and dying. Now, all of these kids are accumulating ACEs. They're building up pretty high ACE scores. Those high ACE scores don't have to be destiny, but if, as a society, we don't do enough to help mitigate that impact, we and those kids are going to pay a heavy price just a few years down the road. So how do we do that? Well, wraparound services, holistic and often whole family with continuity of key relationships over time, are a key to preventing substance abuse and a host of other problems among young people considered at risk. We need to support the kids and those who are caring for them, just as we need to support people who are struggling with a substance use disorder and their families. We have to remember that one person has the disease, but the whole family is suffering. We also need to keep in mind that wraparound services, such as assistance with housing, employment, and transportation, can be crucial in helping people with substance use disorder maintain recovery and in helping people exiting the correction system, many of whom have a history of substance abuse, successfully re-enter society. So how do we do all of this? How do we tie this together? Well, in my view, we need to integrate primary care and behavioral health, including treatment for mental illness and addiction, and link the medical services to an array of wraparound services for individuals and families. Of course, this is going to be much easier to do with value-based payment policies. Addressing the social, behavioral, and environmental factors that adversely affect patient health and increase costs can benefit from the development of strong, community-based, cross-sector coalitions. In Indiana, we're seeing a growing number of such coalitions that are bringing people together from businesses, healthcare entities, educational entities, local governments, law enforcement, and the courts, philanthropies, community-based organizations, and faith-based organizations. They're bringing people together with a focus on a common concern, learning from each other, and seeking ways to use their respective skills and other resources together to cause some good things to happen that otherwise simply aren't going to happen. Some of these are really having some significant impact now. Some of those coalitions are being staffed by navigators who help connect people with wraparound services they need and provide continuity of relationships over time. And we have one coalition in Indiana that was formed several years ago to address an issue related to children in need of services that is finding that the strong relationships that have developed among many of its members are now enabling it to play an active role in addressing the impact of the opioid crisis. In many communities, we have much of what we need. And in smaller towns and rural areas where some services simply don't exist, technologies such as telehealth can help fill the gaps. But we must reduce the fragmentation, integrate services, work with people holistically, often with the whole family, and with key relationships that last over an extended period of time. This will not only help reduce current and future substance abuse, but it will also help reduce other problems as well, help kids develop and strengthen families. And to the extent that we're able to do that, we will also be building stronger, healthier communities for all of our citizens. Thank you.
So Jim, don't move. We love to take a question. Go ahead.
Yes. Hi.
My question for you is, how important do you think it is to pay attention to the perception of drug abusers? And do you think that is necessary to also address issues like the 80s crack epidemic and how that was handled?
Absolutely. I'll tell you, stigma. There's an enormous amount of misinformation around substance abuse, particularly the opioid crisis, and stigma in general. And it's a huge barrier to effective harm reduction and treatment efforts. When you talk about HIV and AIDS, of course, strong association there with injection drug use and the use of dirty needles. Some of you, if you've been focused on that issue at all, you're probably aware of what happened in Scott County, Indiana, back in 2015. But it's a little town, Austin, Indiana, about 4,300 people, and they were having this enormous outbreak of HIV, and it was due to injection drug use, people using dirty needles, and the State Department of Health. Jerome Adams was the commissioner then. Jerome is now the U.S. Surgeon General. He and Dr. Jennifer Walthall, who was his number 2 person at Health then, is now running the Family and Social Services Administration in Indiana. They worked together. They convinced the governor to take steps to open a syringe exchange program in that county. In this small county, they were averaging 20 additional cases of HIV diagnosed every month. When they started that syringe exchange program, it dropped to 2 a month. If you only look at that from an economic standpoint, the savings are just enormous when you consider the lifetime cost to treat someone with HIV or AIDS. But that's not even factoring in the human cost. So that has been sustained. But there has been enormous stigma that has made it very difficult to replicate that in many of the counties, and particularly in the rural part of Indiana. It's probably true in a lot of states and in more rural areas, but it is a hugely important factor, and one that we're strongly supportive of syringe service programs. I can tell you that. I could go on and on, and I guess I already have.
So let's give Jim a hand. Very thought-provoking issues. We've talked about the real-world relevance of data that connects populations for clinical trials and related research. And then, this whole notion in my space, we talk about caring about what happens from the neck up as much as we do from the neck down. So asthma's okay, cardiovascular disease is okay, diabetes is okay. But frequently, we forget about the mental and behavioral health. And in the work that we do, we know that the incidence and prevalence of CVD, or cardiovascular disease, and diabetes co-occurs frequently with issues like depression, among others. So we cannot disconnect those stigma-ridden issues with those that we may feel more comfortable about when we think about the whole person, right? So again, continue to bank your questions. This is a really important discussion. So next will be Dr. Patrick O'Neill. Dr. O'Neill was appointed Commissioner of the Georgia Department of Public Health, July of 2017, by Governor Nathan Deal. As Commissioner, Dr. O'Neill oversees various state public health programs, the Office of Vital Records, where we get a lot of our data for our research, and the Georgia Public Health Laboratory. In addition to his role of commissioner, Dr. O'Neill serves as the Department of Public Health Director of Health Protection, where he has oversight responsibility for emergency medical services, or EMS, and trauma, emergency preparedness, epidemiology, infectious diseases, immunization, and environmental health. And I ask him to come now to share his insights and perspectives.
Thank you very much. It's really a pleasure to be here today. I'm in my 50th year of practicing medicine, and I need to give you a little bit of a background. This is my 5th career, actually. It's been bizarre. I started off as a flight surgeon in Vietnam. Then I practiced family medicine for a brief period, an even more brief period in pediatric oncology. And then for 29 years, I did emergency medicine. And for the last 17 years, I've been in public health. And of all those different careers, you might sort of get the feeling, jack of all trades, master of none. That's right. But public health has been the most exciting and probably the most rewarding that I've been dealing with. this gives you a little bit of a picture of the complexity and also the comprehensiveness of public health in Georgia, the way we're structured. Georgia, second to Texas, has the largest number of counties of any state, 159 counties. And every one of those counties has its own health department. And every one of those counties has its own board of health. We divide the state into 18 different health districts. Each of those district health directors actually have dual bosses. They work for me, but they also work for their county health departments. And if you happen to be a county like the Waycross area down there, which is Ware County, there are actually 16 counties in that district. So that health director has really 17 bosses, me plus 16 boards of health. So you can imagine what a tough job that is, because we almost never agree. And the poor district health director is stuck in the middle of all those disagreements. So essentially that's the complexity of our state. And it's also, from my perspective, it was problematic when I first got into public health because we don't really have the ability to control and mandate very much. We primarily operate as a hybrid state. Local control is much more powerful than central control. And essentially, I offer carrots by passing money down to the districts, largely from federal grants, but also from state funding, with certain deliverables that the districts are expected to accomplish. I don't mandate it, but if they want the money, they have to do it. So it's a nice carrot. It works pretty well most of the time. This is essentially the mission of public health, and I think it's important to focus on the fact that I like to think that we're all about population health. But if you think back to that map, there are some counties in Georgia, particularly in southwest Georgia, where the only delivery of health care is through the local health department. And that may be a public health nurse. So as much as I like to think population health, we still are in the business of primary care in certain parts of our state. I wish we weren't, but we are. My focus, however, from the state perspective is really to think specifically about health and wellness. How do we promote that? How do we make Georgia healthier than it's been? And the other thing that a lot of people don't think about with public health, and this is also not so much from the population health perspective, but we, since 9/11, and actually a little bit before that, we have been charged with preparing for and responding to disasters. And currently, we're still in the process of responding to Hurricane Michael down in southwest Georgia. Most expensive disaster Georgia's ever faced. It's costing us, as a state, over $3 billion for just those 14 counties in southwest Georgia. So that's a very important part of what we do, and an area that I have a special interest in. Now, what are the priorities, though, for public health? And you may sit back and say, well, that's kind of crazy. You know, early brain development, top priority. Why? Opioid epidemic, second priority, even though it's first priority at CDC. And cardiac care system development, that's our third priority. Now, why early brain development? You know, what does that have to do with population health? We have a host of programs that are involved in early brain development. And I don't know if any of you have followed the research that has come out of Harvard on early brain development, but it's absolutely compelling. And as a result of that research, we have started our Talk With Me Baby program. And essentially what this does is, my predecessor, Brenda Fitzgerald, used to talk about not just physical nutrition, but language nutrition. And what difference does that make? If in fact you're exposing your baby, probably even starting in the last trimester of pregnancy, but certainly at birth, to language. Not just words, but caring, loving, nourishing words. Those babies develop neural pathways that otherwise don't develop. And you really only have 2 years to do that. If you start that language nutrition after age 2, those pathways don't develop. And there's very strong evidence to support this, both with electroencephalography as well as some CT imaging studies. But if in fact you start that language nutrition early, you may have seen something published several years ago called the $30 million word gap. No, it's not really 30 million. It's probably much less than that. That study's been debunked to some degree. Nevertheless, there is a significant word gap. And essentially, those babies that have had that type of language nutrition do have tremendously more words at their command than those babies that have not had it. And by age 3, those babies are really making major progress. By age 8, which is generally 3rd grade, they're no longer learning to read, they're reading to learn. But more importantly, perhaps, than what they do academically is how they develop socially. Those babies that have had that language nutrition are much more socialized. They work in teams. They're not disruptive in school. They're there to learn. They're to work with their partners, and they can become very valuable in society. Now, I was really impressed with some of the comments that Jim made related to the wraparound services. Because, you know, when I was actually practicing emergency medicine, I used to think that when I sewed up a cut, wrote my prescription, gave the tetanus shot, that I was finished with my work. I never gave any consideration to whether or not that patient had a way to get home. I never gave any consideration to whether or not that patient had the funds to buy the prescription. I never gave any consideration to the fact that maybe the reason that laceration occurred was because this person was dealing with depression or anxiety or substance misuse, any number of things. I didn't think about what we now call social determinants of care. I thought my job was just to sew up the cut, write the prescriptions, give the shots, that was it. Nowhere near what we should have been doing. And in public health, we see the value of all those wraparound services that do address the social determinants of care. And if we don't address those, just dealing with that one single focus isn't going to work. It's not going to work well at all. Talk With Me Baby is something that we now have in all of our birthing hospitals in Georgia. Our nurses in those units are taught to model this. It's extraordinarily important. Our home health nurses that are taking this into the homes to meet with new mothers are also continuing to model this. And if there is one thing that I think is going to provide a change so that we're no longer chasing our tail, dealing with the after effects, such as the individual who doesn't graduate from high school, who grows up in poverty, who develops some type of substance misuse perhaps, who may be subject to homelessness, who probably has some mental abnormalities as well, and who perhaps lives in a food desert, or if not in a food desert, they don't have enough revenue to go purchase the right foods. So what happens? We see obesity, we see heart disease, we see diabetes. And all of those things we're chasing our tail after. Yeah, in those counties in Georgia where we don't have any other healthcare delivery, we still do that. But why don't we get ahead of the game? Why don't we start dealing with those babies? Language nutrition, physical nutrition, exercise, so that we don't have to deal with the after effects. That's where the return on investment is greatest. And it involves all of those issues of social determinants that can be prevented in the first place. So on the opioid thing, what's the role of public health in Georgia? We have a very important role, but it's limited. Everybody in Georgia has a role in dealing with the opioid crisis. And I would be very quick to say, not just opioid. Yeah, we're going to be able to control that pretty quickly. But what I don't want to have happen is that people turn to illegal drugs after we have curtailed the legal prescription drugs. We've seen some states where the death rate from illegal drugs has been 4 times as great as the death rate from legal opioids. So it's not enough for us to plan to deal with the opioid crisis. We got to think addictive disease crisis. And much of that should be prevention. What was the role of public health? We were asked to craft the state strategy, which we've done. We didn't write it, we crafted it. We put together 6 different working groups, 400 people altogether. And from those working groups, we put together the strategy for the governor. It's a long strategy, it's almost 200 pages. The governor asked me to give him a 1-pager. So it was quite a nice summary. But look at this particular graph, and what you'll see is that in 2014, for the first time, the death rate from overdoses in Georgia exceeded the death rate from car crashes. Now, right after that, the reverse happened. What was that due to? Distracted driving. Now with hands-free, maybe that's going to turn around. It's been kind of neck and neck for the last 2 years. I suspect next year we may actually see overdoses exceed crashes once again. Regionalized care is another very important thing that public health does. And this is down to our third priority, which is creating a system of cardiac care. Now, we've done this with trauma. We started that in 1981. Nowadays, we have about 24 designated trauma centers in the state of Georgia. We can get any major trauma case into a trauma center within the golden hour 95% of the time. And the death rate for major trauma is dramatically reduced because of that. We also have stroke centers throughout the state. In response to Ebola, we created an infectious disease network. And all of those, along with what we're doing this year with our regional perinatal centers and also with developing cardiac centers, we are regionalizing care so that we know that no county in Georgia is going to be able to afford the highest level of care across the board in every subspecialty. Unaffordable, can't be done. So what do? We provide that in regions around the state, but we have to have a transport system so that paramedics in the field can make proper determinations of who needs to go to what level of care. And if they show up at a level that can't care for them, there's the ability to move them quickly to the level where they're needed. So we're doing that with the cardiac system now. We start designation of cardiac centers. Level 1s will be the open heart centers. Level 2s will be the PCI or percutaneous intervention centers. Level 3 will be all of the other centers, the standard emergency departments across the state. That's the only economic way that care can be provided. And the most important thing with regionalized care is that every one of these systems has a registry. And what do we gain from registry? That's data, that's surveillance. And the most important return on investment isn't the care that's being delivered there, it's figuring out the prevention. So once again, prevention, far more valuable than the actual treatment. Even though our systems of care are focusing on treatment, the bottom line is we're getting a lot more data, more useful data, and we're going to improve our prevention. Thank you very much.
Do we have a question for Dr.
So, I'm Craig Zimring at Georgia Tech, and you heard, if you were here this morning, you heard, or earlier in the afternoon, you heard Jennifer Walthall talking, and I would just advocate, and I'm sure it's on your radar, but brain health at the other end of the age continuum, which is that, you know, as we started to work with Emory Brain Health, 20% of people over 65 will have mild cognitive impairment in their lifetime that will affect daily living. In many of half of those cases, it goes on to Alzheimer's disease. It is an issue of management as well as prevention. So I just advocate for brain health at that end as well.
And we're right there with you. The First Lady of Georgia, Sandra Deal, has been very, very influential in that endeavor. She set up, when Governor Deal first came into office, the Children's Cabinet, where we focused on early brain, but she also set up the Older Adults Cabinet. I sit on both of those. And what we have just within the last 6 months done, we've changed our emphasis from just early brain to the entire spectrum of brain development and health throughout the ages. So you're on target.
Much, Dr. O'Neill. So again, rich discussion of connecting the dots across all of these important spaces. So I suspect that Vivian she's clearly been listening, and it's great when you're last because you actually get to connect the dots with respect to how it's relevant to your own work, right? So Vivian Singletary serves as director of the Public Health Informatics Institute, a program of the task health practitioners' ability to use information effectively. So Vivian's experience combines almost 20 years in systems development and in public health. Earlier in her career, she served in leadership positions in supply chain management and information systems implementation for Home Depot and M&M before transitioning into public health. She was introduced to the Task Force for Global Health in 2009 as the Global Supply Chain Manager for the International Trachoma Initiative, where she oversaw the pharmaceutical supply chain of over $1 billion in Zithromax donations, and built in-country capacity for over 15 African and Asian countries. So I think I've said enough. She shall say the rest. So come on, Vivian.
Thank you. Let me see if I can turn this on here.
It doesn't work out.
All right, let me see. Okay, can you hear me?
Yeah, I think you're.
Okay, perfect. All right, so, I mean, I guess it's a good or a bad thing being being last. So, actually, Dr. O'Neill, thank you for setting me up, because my talk here today is really all about prevention. But again, my name is Vivian Singletary. I'm with the Public Health Informatics Institute. We are a program of the Task Force for Global Health. We're based here in Decatur, Georgia, so just a few miles outside of Atlanta. And as was already stated, the mission of the Public Health Informatics Institute is to really improve health worldwide by transforming practitioners' ability to use information effectively. I also must give a plug that I am a Georgia Tech alumni. I actually graduated from the Industrial and Systems Engineering program here as an undergrad. So I joined Jennifer in that same regard as well. The other thing I just want to point out a little bit more about the Task Force for Global Health. We've been around for 35 plus years. Right here in Decatur, Georgia. A lot of people don't know about us. We've been slowly trying to build up our name and profile here more in the U.S. People abroad know us much more. Most of our programmatic focus is outside of the U.S. But there's two major things that the Task Force for Global Health does that's really trying to focus on large-scale disease elimination, so a focus on neglected tropical diseases, and also building up health systems. And that's the focus really of the Public Health Informatics Institute. Our group falls under that focus. There are about 8 other programs at the Task Force for Global Health, so I invite you to check out our website and learn more about who we are and what it is that we do. So, I'll skip that. So I want to start with this quote: "An ounce of prevention is worth a pound of cure." And I can't speak about moving from sick care to health care without speaking about prevention. And a lot of what we've talked about today really kind of focuses on the larger health system ecosystem, essentially. You know, it's not just what you get when you go into the clinic. This particular quote was coined by Ben Franklin, and when he was talking about it, he was really talking about fire prevention. But I think this definitely applies to your health as well. So what I want to say in terms of prevention, we spend most of our lives outside of clinical health care. You know, we don't spend a lot of time with a doctor. We have these episodic moments when we go in to see a physician. Maybe we're driven there because we're sick, or maybe we're just going for a normal healthcare checkup. But what's important is what we do outside of that system. It really is predicated, our health is really predicated upon our habits, and habits related to, you know, your vaccine choice. Are you going out to get vaccinated? How are you eating? How are you sleeping? Are you exercising? You know, what is your tobacco or drug use or alcohol use? These are things that we do on a day-to-day basis that we as individuals can make a choice about to help influence our health. Now, this doesn't say that hereditary, there's some things that you're born with, including me, that I can't get away from. But, you know, we do have a choice, and we do have a big say in how it is that we live our life, which influences our ability to be well. All right, so while we're starting out in the midst of flu season, I have to put a plug in here about flu vaccine. And I would be remiss if I didn't give you some stats. So these are complimentary from CDC. And this is for our 2017-2018 flu season, which was fairly virulent. I mean, it was pretty tough this past season. They reported that there were over 40 million flu illnesses, 900,000 hospitalizations, and 80,000 deaths related to the flu in this past season. And of those deaths, there were 180 pediatric deaths. And I'm pointing this out because this is something that we can make a choice to, go out and get your flu vaccine to have something that's preventable. Just think about the impact, the cost, and the economic impact of, people that you work with, people that you go to school with, in terms of them, having the flu and being out. There are huge impacts. Or just 900,000 hospitalization. The crush on healthcare insurance is very expensive when we can do something to prevent that. And so I just kind of want to start with there. So, again, this is your choice whether you do this or not, but this is something that occurs every year and something that we need to consider as we, think about moving from being sick to being well. I also want to point out a few other things as it relates to public health and some breakthroughs that we've made in public health in terms of the interventions and what we should do to remain healthy. Beyond the flu vaccines, there's other vaccines. If we've all been children ourselves, we've probably gone through the series of vaccines out there. And there are others that are out there for, adults as well. As you get up to, as you kind of reach a certain age, there's other things as an adult that you should be looking into, including, pneumococcal vaccines, the shingles vaccines, etc. But these are things that we can do to be well and take those on ourselves. Other breakthroughs in public health interventions include sanitation. Many years ago, there was no such thing as, getting your trash picked up, but now there is, which is good because that keeps, your area clean and, rids it of rodents and things that can pass on bad bugs to you. But other things that are out there that help us to remain healthy, including, the restaurant inspections and what we do to, enforce sanitation, making sure not your healthcare workers, but your restaurant workers are cleaning their hands, etc. These are all of the things that we can do to be healthy, whether we're working in these environments or we're participating in these environments. These are things that we should be cognizant of and aware. Other things that we've kind of taken for granted, and not so much, these are things that we don't worry about here in the U.S., but when you think about developing countries, having clean water, that helps you, to continue to be healthy. Having OSHA standards, work standards for safety, seatbelt laws, making sure that you're buckling up. There's tobacco cessation programs. These are all of the things, and there's also been, from the public health perspective, water fluorination to help cut down tooth decay, and those are programs that have really been successful here in the U.S. as well. So these are just examples of things that have been put in place here in the U.S., which may not necessarily be the case when you think globally as well, but things that we should think of in terms of moving from sick care to health care. So in closing, like I said, prevention, you can't talk about, being well without prevention. So this is what I leave you with. I say, get your flu shot or your other life-saving vaccines. If you're smoking or you need help, to stop, make sure that you get help so that you can stop with the smoking. Buckle up if you're riding or driving, and make sure that you're exercising and eating well, and make healthy choices overall for your life. Thank you.
Okay, Great. So do we have any questions specifically? There we have one already.
Yes. Do cultural considerations like home remedies, do they have a place in how physicians address patients?
Huh, that's a really good, I mean, I use tons of home remedies myself personally, but I mean, I think there are physicians out there, some that are more holistic in their approach than others who will just write you a prescription. I just think it depends on the physician that you, choose to seek out.
I mean, does the state push for like that type of training for doctors and stuff? Because I find that even I got my flu shot, but the responses I got even from family members was, "You got a flu shot?" Because it was my first time.
Well, from the public health perspective, we definitely promote that, so we promote people going out and getting their flu shot. Most physicians, if you go see them, particularly this time of year, they will promote that just they know that that is for the wellness and prevention for their patients. Is that kind of getting to answer your question?
My only question was, are like physicians trained to talk about the cultural differences?
Oh, are they trained? I don't think that's trained in medical school, but I'll leave it to the MDs that are here. Maybe they can jump in and talk about that because I'm not an MD myself personally, but I'm not sure about that.
Right.
It's changing tremendously. When I was in school, that was not discussed. But nowadays, you'll find it in almost all curricula in medical schools. Cultural competency is critical.
So let's give Vivian and all of our panelists a hand. Very thought-provoking considerations when we think about research, when we think about data, public health, and also the importance of mental and behavioral health. So I hope you all have been storing and banking your questions and comments because now the floor is really open for us to kind of dig deeper into some of the issues that have been addressed. So please feel free, raise your hand and go ahead with your question. I'll yell, and we'll have the microphone go around. And as folks tee up their questions, thank you, Pinar. I have a couple to kind of warm us up.
Now that I have the microphone, I'm going to do a little advertising. So Vivian was talking about vaccinations. For children, there's a published vaccine recommendation schedule, and similarly for adults. In the United States, other countries looks a little bit different. But if you fall behind with your vaccination, whether you are a child or an adult, then you need a catch-up schedule. So we developed here at Georgia Tech in collaboration with the CDC a catch-up scheduler, which is freely available online. So you can look it up, VAC scheduler, vacscheduler.org. So make sure you stay on with your vaccinations. Okay, so now I'm going to pass it on. There's a question here.
Maybe can I just
So we'll
jump?
take a couple of questions, and then our panel is going to respond to them in some combination. So if you are thinking about a question, raise your hand, and I'll bring the microphone.
This question is for Dr. O'Neill. How are the cell phones usage and computer usage affecting mothers talking to their children? Because I see children on the bus all the time playing with their mom's phone, or the mom on the phone looking at a movie and not talking to the kid at all.
Can you say your name?
Oh, my name's Isabel Tamarano, and I work for the Georgia Tech Library.
Thank you
I
very
think it's a
much.
mixed bag. There are certainly some apps that do have some value, but I think that perhaps the disadvantages in many instances outweigh the advantages. Sadly, too many people are using those devices in lieu of developing conversations with people, and I think that's a downside. And it's that, particularly with the early brain development, it's that loving type of communication, verbal communication, that makes a difference. You can put the baby up in front of a TV all day long and it doesn't work. Those pathways don't develop. But if it's the mom talking to that baby with love, that's what allows those pathways to develop.
Great. I think Bridget, were you going to say something?
I was just
Yeah.
going to, can you hear, no, does it work? Maybe
can
if
hear
you're
you. Go ahead.
really close. So just maybe going back to the flu side, I'd say if you think about it from a digital intervention perspective, there's also the side that we've been doing research on using digital interventions where through an app you're giving people information about why you should get a flu shot. Diabetics particularly should get a flu shot in certain cases. So it's about providing data to people at the right time when they're potentially near a CVS. When can I go get a flu shot? So I think there's an aspect that we should be thinking about how the digital tool may also be able to play a role in making sure people do get the information and they do get vaccines.
There's another area too that I think has been very valuable in terms of the devices. In tuberculosis concerns over the years, we know that what we call directly observed therapy works, where you have usually a nurse or a healthcare provider witness that an individual is taking their medication. In rural Georgia, we very often don't have the ability to get a nurse out to the home to do that. But we now are providing it with devices. We're actually letting the nurse in the health department watch what the patient is taking in their home.
I have the microphone, so I'm next. This is mainly aimed, I think, at Bridget. You were talking about how the data gathering work that your company does is intended to be either a replacement for perhaps something that you would add to the gold standard of randomized control trials. Has any of your work so far allowed a comparison between what you get out of RCTs and the kind of work that you're doing? And also, do you have experience so far with the FDA in how they're responding or how they're reacting to the kind of data that you're gathering as opposed to RCTs?
Say your name.
Oh, I'm Richard Bark from the School of Public Policy here at Georgia Tech.
So Bridget, hold it while you think about your answer. I'm going to take one or two more questions so that the panel can respond to them in. Was there a question in the back? Okay, two questions in the back. So let's take these.
Keep it straight, panel. You have a few questions
Make
to
sure that our
bank.
panelists have a chance to breathe in between.
Yeah.
Go ahead.
Oh, yeah. Hi, I'm Francis LaRosa. I work for Piedmont Healthcare. It's a hospital system here in Metro Atlanta. My question was around how you incentivize some of this primary care, any preventative care or primary care activities that exist outside of the hospital. Can you comment on anybody who's doing value-based care right and incentivizing these healthcare systems to invest in these non-hospital, non-acute care interventions?
So that's actually a great question. So we discussed earlier, sometimes incentives may not be entirely aligned. I mean, a lot of our hospitals and clinics need patients to come and get care. And if everybody suddenly gets healthy, they would be out of business. So how do we make sure that we have things aligned, that actually we have more motivation to spend time, effort, and money on the prevention side versus the treatment side? Great question. Thank you. With another question in the back?
Hello, my name is Peng. I'm a master's student in operations research. So since I study mostly about technology and machine learning and statistics, I have a question related to integrating technology with modern medicine. So what do you guys think of the possibility of using like robotics or artificial agents to diagnose a disease or even doing surgeries? Yeah.
Thank you very much. Okay, we have one more question here, so we'll take one more question. I hope you guys are taking notes, right? So you'll remember this question. It's going to come back to you in a minute. Go ahead.
Hi, my name is Mike Tassin. I'm a second-year MBA candidate here at Tech. My question is also about machine learning. As machine learning sort of lowers the cost of making better predictions, both on the clinical scale and on the system scale, what do you think will be the complementary resources or skills that will increase in value as a result of this new set of tools that we'll be using?
All right, one more question, and then I'll pass it back on to the stage.
Hi, everybody. My name is Shireen Brown. I'm a Georgia Tech alum. I also work at the Task Force for Global Health. Given that there's such a proliferation of health IT and data in the private sector for healthcare, how do we move that valuable data set or sets to public health to ensure that we have a healthier population overall?
Did we get enough questions? Okay. You are ready? All right, pass it back on to you. I'll leave it to you. You have one?
Should I start with the first one? I still remember the first question. So I guess just from what we do, I would say 80% of the studies we do are more in a feasibility setting. So we're really looking to gather a lot of data to understand then, can we see any patterns in that data? Ultimately, I think we look at it as this is additive to that randomized control trial. We're not trying to replace it, but we do think that the digital signals can be surrogate endpoints that potentially will either replace some current endpoints in clinical trials, or again, give you a better picture of maybe quality of life, other aspects that are typically hard to really quantify. But I do think there are some points where we are already working with FDA. I think what we see, a lot of what we do as what we would call kind of a tool that can be used in a trial that either is identifying the right patient for the right drug or device, but it also is a tool that potentially gives you that endpoint data that tells you this device can be approved, much like you have a genetic test that identifies the right patient to get a drug. This is now a digital signal that tells you this is the right patient to get that drug or to get that device. And then in the real world, you can continue to really measure how that's doing for a broader population. But FDA is they have an entire digital health sector. They're very engaged in this process.
I'll comment on the questions related to integration and financial incentives. The success that we're having in Indiana is really through our Medicaid system. We are a Medicaid expansion state. We got a waiver early this year from CMS that enables us to provide a really comprehensive array of services for people with an opioid use disorder, and it's a package deal, and that's working relatively well, I would say. The example that I used in my remarks with the safety net provider in Indianapolis, that was through their federally qualified health centers, and that also was through a value-based payment plan. I'm finding I talk to some of the biggest health systems in the state about the need to do a lot more integration of primary care with behavioral health. There's a recognition that needs to happen. There's a lot of resistance among some who basically, I would just say, tend to maybe drag their feet a little bit. But it's happening more and more frequently, and I think that's a very good move. Some of the other FQHCs in Indiana have co-located, at least co-located, primary care and behavioral health, and that's making it much easier for people particularly people with an opioid use disorder, to be able to access primary care as well as behavioral health. This is something that is not going to happen overnight, but we see some positive movements in that direction.
I'll mention one other situation where I think incentives are important. There's a situation that's often referred to as community paramedicine or mobilized integrated healthcare. And there are some healthcare systems that have actually funded paying paramedics to essentially function as case managers in the field rather than doing transports, following up particularly with Medicare patients to be sure that they are following the recommended guidelines that they had when they left the hospital. And the savings for those systems based on keeping those patients from representing within the Medicare limit timeframe has been significant. a major incentive to support the funding of those systems.
There was a question about moving data to public health to help with interventions. I mean, right now the data that comes to public health is really more around reportable conditions and diseases. And because infectious disease is not what's really the big killer in the US anymore, there needs to be a move to really get chronic disease data moved from healthcare into public health so that they can begin to study it and understand it and begin to make recommendations for interventions. Because chronic disease is not mandated in terms of the reporting from providers to public health, there definitely has to be a development of a partnership between healthcare and public health so that there is the value case that public health can show back to healthcare providers to incent them to share that data because it is not a state mandated, component there.
We're making some headway in Indiana in doing this. About 2 years ago, a management performance hub was created. It's under the Office of Management and Budget, office in the State House, and we worked pretty hard actually for a few months last year to get a data sharing agreement across almost all of the relevant state agencies that are concerned with health issues and some of the others as well. But we finally got that, and there's a lot of data now flowing into that hub, and they're augmenting that with sets of data from outside of government on a variety of factors, including increasingly more data on social determinants, factoring this in. And I was actually in a meeting yesterday afternoon where we were looking at some of the results that they're coming up with. They've got some researchers from one of the local universities working closely with them, and some really interesting insights beginning to appear. There's a lot of value in this, I think, and not only in helping us understand better what's happening now, but also getting us into a position where we'll be much better able to start using more predictive analytics to get ahead of some of these things. I mean, this opioid situation, I think it caught our state and probably most states we were all playing catch up. Nobody got ahead of this. I don't know that anybody really saw what was happening until it was really quite a serious problem, and we can't let that happen again. We've got to have an early warning system and be able to spot some of these things that are happening, and be able to intervene before they get anywhere near as bad as this opioid situation did. And data is just absolutely essential to our ability to do that.
Great. So we are within an academic institution, and we have a lot of learners, as well as those who mentor and train those who will be the next generation of researchers, practitioners, policymakers, etc. So from where you sit now, both the Georgia Tech alum who are now in the field and those who are in the public health trenches, what do you think educational systems need to be doing to educate the next generation of leaders in health systems and help move things forward in a positive direction, particularly when we think about preparing them for some of these emerging health crises? So think about what your learning process was like and then what you're seeing now. What do educational systems need to do to prepare that next generation?
I think what's happening here today is part of it, and I certainly give kudos to Pinar for bringing this about. I think this is a tremendous opportunity to do just that very thing. 50 years ago when I was in school, this wouldn't have happened.
I don't even remember anything that learned when I was here. But I will tell you two things that really, really have been important to me throughout my life. I learned to work very hard under pressure, and I learned how to manage my time, because if I couldn't do both of those, I wasn't going to get through this place back in those days, and probably not today either. But I think that I think Pinar mentioned this in your opening remarks about the projects that students get engaged in, and be sure to connect with what's happening at ground level. Be sure that this has been a kind of a pet peeve of mine with a lot of public policy stuff, where people. The thought leaders and the policymakers tend to talk to each other, and the people who are actually doing the work at ground level talk to each other when they have time. And so often there's just a gap. And some of the policies that don't work as well as expected, well, it's because they really didn't understand the realities. And I think that's just absolutely essential. So somewhere in all of this, be sure that that's happening. And my impression from the contacts that I've had with Georgia Tech over the last several years are that that's happening a lot more here than it is a lot of places.
I would just add to that, knowing how to think about problems. And I think, for all of the students that are here at Georgia Tech, I think Georgia Tech does a very good job helping you think critically, because this is the problem today. The problem will always change. There'll be a different one. So I would say knowing how to critically think through issues and be innovative and creative in your approaches. Those are things that are very important when you come out here in the real world, because the problem will change and you have to just be ready for whatever is presented to you, and you have to have the logical approach to dealing with the problem that's been set in front of you.
Yeah, I'll just add, I'll even go back further and say it's about first defining what the problem is. I think a lot of times we jump to, this must be the problem, and we try and solve that. I think part of what I guess I would say I've learned recently in this digital health world, where we are half a tech company, half people came from the Googles and the Facebooks of the world, and half the people came from a healthcare world. It's being able to sit down with the other side and really understand how to solve a problem, but in a curious way where you want to learn from the other side. And that's, I think, a really important part, is to sit down and say, let's understand what the problem is first that we're trying to solve.
So I enjoy, I think my most fun time is engaging with students, right? And hearing their innovations, right, in terms of the way that they view the world. So I really invite, before we close, some questions from our students. You all, this is a rich opportunity, and I know Georgia Tech, Morehouse School of Medicine, and many of us who are collaborating across really the street or the highway now to think about how to create opportunities like this for our learners. Are there any questions that you have for our panelists, given what your career trajectory is, what you think it is today? Let's take a few minutes to pick their brains in terms of questions that you might have, given this safe space that Pinar has really facilitated. Yeah, or former students. There's one in the back.
Yeah, my question earlier was about machine learning and sort of as the cost of making better predictions comes down, clinical space and system-wide. What do you think, as a result, sort of the complementary resources or values that will increase in value as a result of introducing these
I personally think that's going to be even more important, particularly when I hear of all of the data that's being collected and will need to be analyzed. When we analyze that data, we're going to want to understand the trends, the patterns. We're going to want to understand, what are the recommendations or interventions that we can come up with to prevent some of these things that we'll see in health data. So I think where you're going is going to be critically important because it kind of comes back to that whole notion about prevention and intervention.
Yeah, I would just add, I mean, from a data perspective, obviously there's a lot of data, and that's where machine learning comes in, but it's not just the data, right? It's the so what. What do you do with that data, and how do you make that valuable to the person that can use it? Doctors will tell you, I don't need any more data, right? I have lots of data, and I can't really handle looking at one more set of data. So, and you know, to some degree, you know, Apple Health coming out with now your Apple Watch will tell you if you have AFib. We don't really need hundreds of thousands of people going into their doctor saying, my watch told me I might have AFib, right? But there is value in that, in trying to really understand what is valuable, when can you detect something that maybe wasn't detectable before. But we need to be able to rule out all the other noise that's in there, right? So that's the value of machine learning and AI that we're gonna have. It will continue to grow. From what I understand, it's, you know, we're in 2.0, but where will it be a year from now?
Okay. Is there a question? Oh, there's one in the back, and then we'll come up to you. Go ahead.
It was mentioned that the U.S. life expectancy decreased for the second year in a row. Now, that's a very scary thought. What can we do as students and as policymakers and as the next generation to reverse that trend? And what are some of the major causes of why the life expectancy decreased?
Well, that was one of my comments, and yeah, there are other factors involved. The number of deaths from drug overdoses, which totaled 72,000 in this country last year, was a primary factor. I think there is something. I think Dr. O'Neill said everybody can play a role in this. Learn all you can. Help, you know, educate yourself. Help educate others about this. Yeah, this epidemic began with the overuse of legally prescribed pain medications. This goes back to the 1990s, and the emphasis on treating pain as the fifth vital sign. There's a whole generation of doctors who were basically trained to do everything they could to minimize pain or eliminate pain. And at the same time, you had some very misleading marketing by some manufacturers of some of those products, basically leading a lot of people to believe that there was a very low risk of addiction. And this thing got out of hand. And then what happens is eventually you need more and more because the body builds up a tolerance, and you got to have more just to feel normal. And eventually either you can't get enough pills or they're too expensive, and so you turn to the street drugs, which are plentiful and cheap. If you look at a curve that tracks the rate of opioid sales in this country and the rate of deaths related to opioids, they parallel each other pretty closely from about 1999 to 2010, 2011. And then the death rate starts diverging, and that is a result of the increased presence of fentanyl and other synthetic opioids, which are typically manufactured in China, shipped in. They're extraordinarily potent. They're laced into heroin. They're now laced into other substances. They're put into counterfeit pills that look like prescription pain pills, and this thing has just gotten completely out of hand. So what do you do about it? Well, what I've tried to make sure that people know is that an opioid use disorder, it used to be, and it still is today, viewed by many people as a moral failure. It's something, it's your fault, therefore, you know, tough luck, you know. I mean, I have people questioning me about, well, how many times do we have to revive someone with naloxone? I say, well, as many times as they overdose, because we can't do otherwise. But then they're not going to be able to, you know, they have a chronic disease now. It's affected the structure and the function of the brain. Now, the good news is it's treatable, but this can be a very difficult and a long process. The risk of relapse is very high, as it is with other chronic diseases. And so we have to understand this as a chronic disease that is treatable and that recovery is possible. And that's an important message that the people need to hear. And quit viewing this as simply a moral failure and start viewing it as a chronic disease and treating it as such. And then we'll make more headway. But we also, and we're seeing now, and I think probably it's true pretty much nationally, there's a resurgence in the use of meth. There is the toxicology reports that we see usually involve multiple substances, not just one. In fact, it's rare that it's just one substance. So we've got to do a lot more on the prevention side. I mean, we're doing a pretty good job, I think, of getting the prescription rates down. They need to come down more, but that's not going to solve the whole problem. We have to do a lot more front-end prevention work, and a lot of that needs to be done with the children and youth. There's just so much that, and the most effective evidence-based substance abuse prevention programs for children and youth don't just talk about drugs. Right. They're helping young people learn how to manage their emotions, how to cope with challenges, how to develop resiliency, skills that are going to be helpful not just in school but in life. And these work. Some of them have some really good long-term track. What Dr. Neal was mentioning about the importance of starting with the babies. Oh my gosh, I am a believer in the importance of the early childhood programs. We can't do enough of that, in my opinion, especially with children who are born into homes where the risk factors might be higher than usual. And here I am again, going on and on. And sorry about that.
It's wonderful. Dr. O'Neill, go ahead. Go ahead.
There's one other thing I would ask every student to do, and that's to help us sort of shift this paradigm of talking about illness to talking about wellness.
Yes.
And even on the economics, we need to be thinking about, we should be paying for wellness, not for sickness. But it's going to change, it's going to take a major change in our paradigm.
There was another student here and then one in the front. Go ahead.
So, former student.
Former student, yes.
My question is, so I come from an operations research background, and doing my research, I've had the great opportunity of working with very receptive healthcare professionals. And I know we've been talking a lot about the great things we can do with data, but I find that there's like a very big lack of like science communication from our community to the medical community to maybe do more outreach there. So, in your mind, what do you think is like something that the algorithms community or maybe the analytics community could do to better communicate the kind of tools and approaches that we have to the healthcare community more broadly?
One of the great things, and Jim can probably tag on to this, that's already happening, but I think we can extend this to many other things, and that's with the PDMP, the Prescription Drug Monitoring Program. Every physician needs to know what a particular patient has already received from other practitioners that maybe the patient doesn't want to tell them. And we need to be integrating that data from the PDMP into the electronic health records so that the doctor doesn't have to go into a separate portal to find out. It needs to be part of the work stream.
Actually, you brought up a really good point. I was at a meeting at CDC, and I think there is a small project going on here with Georgia Tech to create exactly what you just stated with the College of Computing, so that there is a pharmacy drug monitoring, and I think there's some type of scale that they have on there to show whether the doctor should prescribe or not prescribe. But I think you're absolutely right. That's so important, so that there's not that over-prescribing going on.
And the system has to be very user-friendly. It's got to be quick and easy for the doctor to get that information. Our system, a couple of years ago, it was just really slow and clunky. And we made a decision, we're going to integrate, we're going to improve it, and that process is well along now, and integrating with the EMRs, but also making it so much faster and more user-friendly. This is really important. So I think there's a lot of room to take that concept and do more with it.
We have a question in the front and then in the back. Did you? Yeah.
First of all,
So I didn't hear the last part of the question.
How you foresee sort of the collaboration between public health and these larger consumer-based companies that are providing the technologies to assist that, or patient monitors, for example, for our health
Okay, so as you all think about that one, we'll queue up the last question or comment.
I think this is more generally, overdiagnosis, overtreatment, because we may be afraid that if we don't do it, then something happens. There's connection to the legal side.
I can chime in about the public-private partnership and just give you an example of one that we have ongoing right now. So number one, I think public-private partnerships are incredibly important. We have one going on now. It's called the Digital Bridge, and it is a multi-sector project that includes public health, healthcare, and health IT vendors. And the focus is on building really that data bridge between the EHRs and public health. So today, and the first use case is around electronic case reporting for reportable conditions and diseases. Today, that process is quite manual in terms of how that data gets from a provider to public health. And we're trying to make that electronic and have that data come across more timely. And because the process currently is fairly manual, there's a lot of underreporting of conditions, reportable conditions and disease. But that's an example where you have both private funding and public funding coming together, really for the good of the people of this country. And I think we're going to have to do more of that to move innovation forward much quicker.
I'll jump in on the legal side, but maybe from the other perspective is that, I think all these digital tools that are coming out have to prove, just like a drug does, that it works, right? But on the other hand, some of the tools that are out there already that are looking at imaging, and using machine learning to read those images and make decisions on whether or not a patient should go in for stenting. A lot of those decisions now actually are showing that we were already over-treating patients and over-diagnosing patients without looking at the data. And now that we have the data, I think there's just as much risk to ignore that data and have a patient go through something that maybe they didn't need to have. So I think it's just as important that the data should be there. It needs to be proven. You need to have the data to show that it works and it is just as good as a physician. But I think in many cases it's actually proving it's better than a physician's view.
The other thing that I would mention is I think that there's a real role for health policy here. The intersection between healthcare and legal is terribly important. And in public health, we have a major responsibility to influence health policy such that that intersection can be more positive rather than adversarial. For example, when the PDMP moved to public health from drugs and narcotics, we had to get the law changed in Georgia such that we could share that information with bordering states. The law did not permit that, so we had to have a major policy change at the legislative level in order to be able to do that. We now can share with all states around us. We can share with law enforcement outside of Georgia as well as law enforcement inside of Georgia. And the law now mandates that physicians, any practitioner that has a DEA number, check the PDMP before they prescribe a Schedule II drug or benzodiazepine. So this is really the law working with the health community rather than adversarial with the community.
We've taken some of the same approaches at Indiana, and modified some of the laws. One of them in particular has to do with immunity of people who are present at the time of an overdose, and there's just great concern that the people who help, as well as the person who overdosed, could be arrested and prosecuted. And one of the things that we've really worked hard on, and still have a lot of work yet to do, is in getting more of the law enforcement and the judicial system, some of the judges on board. We talked about syringe exchanges earlier this afternoon, and some of the prosecutors in some of our counties. By the way, I feel so much better after coming here and finding out that Georgia has 159 counties. I thought we had a lot at 92, but we have some who are on board. They understand it. They're trying to be helpful. We got others who are. It's kind of an old school approach. Similarly with some of the sheriffs, some of them are just wonderful. They really get it, and they're really trying to help and provide treatment in the jails. And it's just. And on the other hand, you've got some who I think would prefer just to lock them up and throw away the key. And there's just so much work that has to be done yet. But we are way beyond where we were a couple of years ago. So I have to keep that in mind. But yes. I think on the legal side, we've worked pretty hard trying to make sure that we've got we've got public policy that makes sense and that's enhancing what we're trying to do rather than detracting from it. We're not there yet, but we've made some progress on it.
Sure. Well, let's give our panelists a hand for all of their insights. I know it is 4:30 on a Friday, so I won't hold you much longer, but I will just bring up a couple of closing thoughts and resources. So for those of you who may not know, there are many collaborations that are here to bring our academic institutions together, but also ways that students across institutions can innovate and collaborate together. And one of them is the Georgia Clinical and Translational Science Alliance. So Georgia CTSA is a collaboration between Emory, Morehouse School of Medicine, Georgia Tech, and UGA, designed to bring together researchers and learners who are interested in how we advance team science, so figure out how what happens at the bench, in the clinical space, and in the community spaces can work together. So team science is what we're about, but there are also great opportunities for students, as well as those who are recent graduates, to get mentorship and support as you think about places where you can play and innovate together, right? So go to georgiactsa.org and you get information on that. So in the spaces of kind of closing thoughts from today, I started with, and I think we've heard today about the importance of 3 critical areas, and one is research, right? So where do innovations in how we treat patients, how we use things like simulation and machinery, and even our social behavioral research, how do we develop research that matters? Not only that's statistically significant, but has practical significance to those in business who may not care about health, but they care about the bottom line. And if communities and other partners are frequently seeing them more, as we heard, than they are seeing a clinician, they should be among our partners when we think about advancing research that matters. The other thing that's really important and that we heard is that there is no health without mental and behavioral health, right? And so we know that mental and behavioral health is a cross-cutting issue, not just for health disparity populations or those that we may choose to target, but even in terms of all that we carry as researchers and practitioners, we need to consider our own behavioral and mental health, extremely important. And then we know that individuals are not alone responsible for the health outcomes of populations, right? So we heard from Vivian the importance of us doing what we can to advance our health, but we don't all start at the same place. We heard very clearly that based on a lot of experiences, both under one's roof or in one's community, people are at different places in terms of the degree of autonomy they have to be able to access health care, have health insurance. And we know that that is different when you're in a rural versus an urban setting. So it's important that we know our communities, whether they're communities of neighborhood residents or communities of practitioners, and meet them where they are towards advancing population-based health. So the last thing I would leave us with is that we should all be focused, whether we're in the research space, we're in the practice space, or in the policy systems and environmental change space, on health equity. And that is people having what they need in the amount that they need it to live their best lives possible. And that takes all of us. So I know that stats are important. I don't have to be a statistician, I just need to know one, right? So collaborations are important. It takes all of us, and thank you to Pinar for facilitating this wonderful meeting of experts to advance population health. Thanks.
It's been an amazing afternoon. I would like to thank once again to our moderator, panelists, rapid fire presenters, poster presenters, and to all of you for being with us today. I'm thankful to you not only for being here, but also for all you do in your day-to-day life, in your work, to help us advance in this space. We heard a lot of challenges. We are making headways in some areas, but we still have a lot of challenges. But we also heard a lot of progress happening. And I think with the next generation, with our younger generation being in the room and paving the way forward into the future, I'm very optimistic. And I would like to leave all of you, hopefully with that optimism and positive thinking, that we can actually move the needle in the space into a more positive environment that's focused on health and well-being versus where we are today. So remember your homework that I gave you earlier in the opening, that you are going to think about what you can do, what your organization can do in terms of impacting your environment as well as the constituents your organization might serve, and also think about motivating others. So hopefully, collectively, we can make a positive impact. If you have not connected with us already, please do so. For those of you who are already connected with the Center for Health and Humanitarian Systems, please engage with us, reach out, and I hope we all stay in touch. Have a wonderful weekend. Thanks again for being here. Thank you.